The evolution of TRT at the Men's Health Clinic. Well, we opened the clinic back in January 2016. And one of the primary goals was to increase access and awareness to safe and effective care. Now, we were reassured that there were guidelines, the British Society for Sexual Medicine guidelines, and if there's one thing the Brits do very well, is safety. So it was reassuring to know that there was some consensus, and there's also a European consensus on how to practice safely. So we started. We used the UK licensed TRT suggestion, which was Nebido. So we did the initial dose, 6-week booster, measured levels at 12 weeks, and then adjusted the protocol accordingly. Now, it'll come as no surprise to people who have used Nebido, who will know about Nebido, that the main issue with it is peaks and troughs. So what happens when you see a patient and the levels come back low in their trough? Well, you shorten the interval. It was getting to the stage where people were on 6 weekly injections and they weren't feeling great. Now, why weren't they feeling great? Because their trough level was reasonable. So say, in between 20 and 30. It's because week 1 to week 6, there was still a peak and a trough. And they were having negative side effects. Not only heightened psychological states, anxiety, they were having estrogenic side effects. Now, one of the shortcomings with the British Society for Sexual Medicine guidelines is they do not recognise the importance of estrogen, nor do they actually recognise the importance of DHT, but we'll get onto that later. But estrogen's the big one, because obviously when testosterone gets aromatized to estrogen, that is the major negative feedback hormone that tells the hypothalamus and pituitary not to send any more LH and FSH down to the testes. So it's incredibly important. Now, we've already spoken about the importance of estrogen in the body, in maintaining physical and psychological health. So it seems logical that we should be monitoring estrogen as well. So one of our guys suggested, why don't we look to the American model? And that seemed very sensible. So we obviously went on to the US forums, and it looked like either testosterone, cypionate or enanthate were the flavour of the day. And so we moved over to using enanthate. Now, what did we do? Well, we followed the guidelines, the manufacturing guidelines, injecting 250 milligrams every 2 to 3 weeks. What happened? Peaks and troughs. Why? Surely they've done the research. Surely they've shown due diligence before launching a product and saying, yeah, inject once every 2 to 3 weeks. Well, what you need to appreciate is basic pharmacokinetics and pharmacodynamics. Now, if you have an appreciation of those two subjects, then you will realise that, unfortunately, if you want to achieve stable levels, and that should ultimately be the goal of testosterone replacement therapy, that does not make sense. You will have a peak and a trough. Now, the half-life of testosterone, enanthate and cypionate is between about 4 and 9 days. Cypionate is slightly longer because it's got an extra carbon atom. It's got a slightly different chemical structure, but so there are compounding factors. Now, what is the major compounding factor? Now, the major confounding factor is SHBG, sex hormone binding globulin. We moved over to injections every 3.5 days, and we saw some great results actually, but we also had some guys who still could not get stable, and the reason was they had low SHBGs. So what happens to the testosterone when you inject it? Gets into the blood system, goes to the liver, has the carbon atoms cleaved, and then it's free to do what you want. So it gets exposed to SHBG. SHBG has a really important role. Now, what role is that? The half-life of testosterone, estrogen, dihydrotestosterone, is really short. So you need testosterone to bind to SHBG because, funnily enough, you need to use testosterone in varying amounts 24/7, 7 days a week. We should actually be looking at our hormonal profiles from a day-to-day basis. So rather than thinking of time as a long interval, we should be day-to-day, because testosterone production is diurnal. So it peaks in the morning and wanes in the evening. So your major anabolic processes happen when you're resting, ergo at night time, and during the day you're predominantly catabolic, so you want cortisol. So these low SHBG guys, they were still having peaks and troughs. So what did we do? We moved to more frequent injections. Now, I'm a massive proponent of daily injections, so microdosing. The premise behind microdosing is using the minimum effective dose in the most effective manner. And as already stated, we should be looking at hormonal profiles from a daily perspective. So a daily injection makes sense. So does that solve the SHBG problem? Unfortunately not. We do have a couple of guys that, shock horror, we're actually using libido on. Now these guys have got SHBGs in single digits and they cannot get stable on cypionate. So what did we do? We moved them over to weekly injections of libido, 125 milligrams every week. One's on 250 every 2 weeks, to be fair. And guess what? They are incredibly stable and they are happy. So the low SHBG guys, even with daily injections, cannot get stable on cypionate. But these are low single figure guys. So we do our best to dial them in, but we have to think outside the box sometimes. Now, we had a negative experience with libido prescribing it as per manufacturing guidelines, but we've had a very positive effect from prescribing it on a weekly basis or every 2 weeks. It's not perfect because the half-life is obviously long, so to actually build up stable levels, and when you think about building up stable levels, you have to appreciate that it takes 5 half-lives. So there can be a little bit of a long drawn out process to get these guys stable, but it's about thinking outside the box. And these guys have obviously done their very best, and we've done our very best to get them dialed in. And because they haven't been dialed in, we've had to think outside the box. So what else is there? HCG. This is another thing that the British Society for Sexual Medicine guidelines does not fully appreciate the importance of. Now, we know that testosterone suppresses the pituitary. Ergo, you are not going to be sending LH and FSH down to the testicles. Now, the primary function of LH is obviously stimulation of the Leydig cells to produce testosterone. But there is also a role in fertility. So also testicular size. You don't want to be part of the tiny testicle crew. And there are LH receptors all over the body. So guys do feel a qualitative improvement in their sense of well-being with HCG in their protocols. Now again, that evolved. So the data says you should inject that twice a week. The fertility research paper says you need 500 IU every other day. But that paper was based on a crazy dose of testosterone enanthate, a weekly testosterone dose of enanthate. And yeah, you know, you're going to be shocked at this, but I've got guys in their 20s who are on as little as 35 milligrams of testosterone stipulate a week, split up into daily injections alongside HCG. 35 milligrams. Well, when you think about how much testosterone gets produced on a daily basis, the latest data is between 5 and 7. Now, testosterone levels are dropping, so you could hypothesize that that is an underestimation. So when you talk about supraphysiological doses, what we're talking about really is what sort of dose maintains homeostasis. So it's not all about how amazing you feel, because how amazing you feel is obviously important because we all want to feel amazing, but it's also working with the other physiological processes and parameters that go on within the body. So you do have to have a modicum of common sense and say, right, well, if my elevated free testosterone is telling my kidneys to produce too much erythropoietin, and ergo I'm having too much HCT, too many red blood cells produced by the bone marrow, that's probably not a good thing. Now that can obviously happen, especially in the first 12 months when your body gets acclimatized to the testosterone. But if that HCT is continuing to stay elevated, it's more than likely that your protocol is too aggressive. And that standard also applies to the HDL. Now, HDL is actually a protein that takes cholesterol away from the cells. Now, over-aggressive protocols can cause a drop in HDL. It's all about how you feel. It's not about how you feel. It's all about long-term physical and psychological well-being. Estrogen. We've touched on that before, so I'm not going to go over that ad nauseum, but that's something that we are going to be approaching the NHS and asking them to take a little bit more seriously. We are actually in the midst of a trial to demonstrate safe and effective practice so that we can present the research to hopefully a big publication paper such as the British Medical Journal, because we want to effect a change. We want to effect a change to how testosterone replacement therapy is viewed and how testosterone replacement therapy is dealt with within the NHS, because ultimately that's what this is all about. Estrogen. Yeah, I mean, I had very strong views about, puritanical views about you should never prescribe an AI. Now, we've discussed this in previous videos. We have a propensity to aromatization. And what we should be doing is minimizing that propensity. But there's no point allowing somebody who cannot do what he needs to do because of the negative symptoms of high estrogen, prevent him from feeling great, because it's all about feeling great. No, it's actually about evolving your process with the patient. So ergo, what I'm trying to do is trying to get you on the least amount of medication possible. So I would like you on just testosterone cypionate or enanthate and HCG. So we are always working towards that standard. So we've said this before, a bad scientist makes closed statements. You should never make closed statements. You should have a principle and a standard that you want to adhere to, but you should always act in the best interests of your patient sat in front of you. So the whole never prescribe an AI, always prescribe an AI, always do this, never do this, it's not actually acting in the best interests of your patient, because obviously we're all individuals, you're all unique. There's lots of chunky monkeys out there. There's lots of people abusing their livers. So, you know, we live in a very poisonous environment where the cattle are pumped full of estrogens, and that's all just draining into our water supply. So it's no wonder that we are having a propensity to aromatization. What about DHT? DHT is an interesting hormone as well, obviously super important. Everybody wants nice DHT levels for libido and muscles. It's another hormone that hasn't traditionally been looked at in the UK. So we will now be offering DHT testing because we do have some guys who are dialed in, who have sort of normal free testosterone levels, normal estrogen levels, but they do lack libido. And one can presume that's because of low DHT. So yeah, watch this space, because that's going to be an interesting avenue to go down, because again, it's not something that's traditionally been looked at by the NHS. Why do we have a slight decrease in DHT when everybody's dialed and everybody's dialed in? Well, it's interesting. I would hypothesize that, again, testosterone replacement therapy, testosterone only therapy, whilst we are trying to mimic natural physiology, we are not perfect at it. So testosterone obviously gets produced by the testicles naturally. Ergo, the testosterone then gets exposed to the 5-alpha reductase enzyme, and you produce DHT. So say if you've got cracking free T levels and estrogen levels from TRT injections, the concentration around the testicles / prostate will not be high, ergo you will not convert so much to DHT. It's just a hypothesis, but it does sort of attempt to explain why you may have a relative decrease in DHT. So I think it's important to have a slightly different approach to how we currently look at testosterone replacement therapy. Irrespective of whether you've got a primary or a secondary cause, or you've simply got testosterone deficiency syndrome with no identifiable causative agent, testosterone suppresses the pituitary. If we look at hormone optimization, we should be wanting to replace all hormones. Now, ergo, we know that testosterone suppresses the pituitary. So it does seem very logical that you should have HCG in your protocol. Now, perhaps we should be looking like this. If you want all of your hormones to be firing as they should be firing, and we know that testosterone suppresses the pituitary, everybody should attempt to at least have HCG in their protocol. Doesn't suit everybody, unfortunately, but we should all, again, it's a principle. They should attempt to have HCG in their protocol and then top up with testosterone. So that kind of makes more sense to me than saying, wham bam, thank you ma'am, I'm going to knock off the pituitary and just give you testosterone monotherapy. Thinking, always thinking. It's just another way of looking at hormone optimization, because hormone optimization is a field that there are widely differing opinions and attitudes. And I think, again, we need to recognize that we are biological organisms. We've evolved over millions of years to the beings that we are. We're devolving because of the pollutants and the crap that we put ourselves through or in. Yeah, we should be working with our physiology, just remembering that we are biological organisms, and there are complex processes that go on within the body to maintain stability, and we do our very best to mess them up. We are often our own worst enemies, and perhaps we should just take a step back and say, right, let's work with nature, not against it.